Hi guys, welcome back to week 7, cardiology, part 1 of this particular week's PowerPoint presentations. There's going to be 2 PowerPoints for this week. One focusing on cardiology in terms of arrhythmias and EKG review, and then part 2 is more heart blocks and just cardiac murmurs. So we'll get into that in the next one. There are a lot of slides in this PowerPoint. I'm going to try to get through them smoothly but quickly. I don't want to really read to you as much as I want you to just know certain things that you really have to make sure you're understanding. Now, cardiology in itself is a big topic. There's a lot to know, especially when it comes to EKGs. So we're going to briefly go over it. I'm really hopeful a lot of you already have a good, strong foundation with EKG interpretation. But we will be reviewing it in this PowerPoint particularly. So feel free, if you're already very well versed in EKGs, to skip through this because it is a lot of information. There's over 100 slides in this particular PowerPoint, and I did include 2 videos just to give you recaps. So in this PowerPoint, we're really going to review arrhythmias and EKGs. We're going to talk about the basic concepts of cardiac conduction, the rate in terms of EKG interpretations and how to calculate it, and what you're looking at in terms of Brady versus tachycardia. We're going to talk about hemodynamics in terms of your stroke volume and how that affects your cardiac output. We're going to talk about the clinical presentation of a patient who is presenting with decreased cardiac output. We're going to talk about the rhythm in terms of different arrhythmias, the heart blocks, and junctional rhythms. We're also going to talk about the 12-lead EKG. It's really important you understand the basics of that, including understanding the access, how to interpret them, and to really be very visually to be able to recognize visually what a arrhythmia looks like when you just glance over at an EKG. There's going to be about 6 that we're going to look at the end of this PowerPoint, and those 6 arrhythmias I really would suggest you just memorize. Just by just visual memorization, because I will say those particular arrhythmias are very common and they do come up on your boards. So I really want to reinforce, it's really important that you learn these arrhythmias. All right, here we go. So again, much of this is a review for a lot of you, but just to refocus, we're really looking at making sure you know how to detect an arrhythmia, the basic hemodynamics of arrhythmias and why they matter, the most common arrhythmias, 12-lead EKG interpretation, and then of course at the end we're going to just do a little self-assessment and practice of some EKG rhythms strips. So the big thing I will reinforce with you, which is what I did when I was in grad school, I looked up cardiac arrhythmias individually and just reviewed on YouTube what they sound like, what I'm looking at in terms of symptoms that are being presented with the particular arrhythmia, and how to actually assess it on the patient, where I'm auscultating to actually be able to hear that particular arrhythmia. So those are the things you really need to know, not only for your boards and your exams, but specifically for your practice, your clinical practice. Okay, so advice for clinical practice. So definitely you want to consider a small size pocket handbook or an app with basic cardiology concepts, images of common cardiac arrhythmias, how to detect them. If you don't have experience in this, in the cardiac realm, believe me, it takes a lot of practice to get used to it and comfortable with hearing and recognizing these particular arrhythmias. So do yourself a favor and gather a little, tool, whether it's a small pocketbook or your own little notes, a notebook with your own notes, or maybe you want to save some of those cardiac arrhythmia videos you find in a particular file on your phone so you can refer back to them, however you want to do it. But just make sure that you have something to refer to that will jog your memory as you're going through this. You want to make sure that whatever you have includes advanced skills like detection of axis deviation and hypertrophy. That's really important in terms of being able to interpret an EKG. Like it says here, it's invaluable if you don't have a comfort level with basic cardiology concepts. And of course, although modern EKG machines diagnose arrhythmias and MIs, you may not always have that at your disposal in your practice. So you need to be able to recognize it yourself. And of course, you want to consider ACLS certification and following ACLS guidelines for treatments of arrhythmias. So definitely, if you're finding you're dealing with a lot of cardiac patients, I 100% would encourage you to go get an ACLS certification. Okay, so method of arrhythmia interpretation. So you're going to give a quick scan of the strip. Is this an emergency? If so, respond. If not, continue with the interpretation. Now, in terms of like giving a quick scan, that's where it's really important. Like at the end of this PowerPoint, when you see those strips of the irregular arrhythmias, or just the arrhythmias, like you need to be able to memorize them and recognize them so that you can do the quick scan and know if it's an emergency or not. And we'll go over that more at the end. So you're looking at a quick scan of the strip. Is the rate normal? And remember, a normal rate is between 60 and 100. Even 100 is a little fast, so just keep that in mind. Is the rhythm regular? These are the basic things you're looking at when you're looking at an EKG interpretation. And, just keep in mind, we're going to keep going over this over and over again. We're going to break it down. So we're doing a quick scan of the strip, looking at the rate. Is it normal? What's, 60 to 100? Is the rhythm regular? We're going to assess our PQRS complex. We're going to look at each aspect of the complex. What does your P wave look like? Is there a Q wave? Look at the ST segments and the T wave. Super important. Are they elevated or are they depressed? You need to make sure you're paying attention to that and do this systematically. That's the big thing with EKG interpretation that you will hear over and over again. Just like if you're looking at a chest x-ray or any kind of x-ray, everything is systematic. Stick with your system so you don't miss anything and you don't get overwhelmed. You want to measure your intervals. You want to identify the rhythm. If you're considering that the patient is having an MI, you need to look for a left bundle branch block, axis and ST-T wave changes in specific leads. Okay, that's going to be your clear indication of whether you're having an MI or not. Keep in mind, an EKG only shows you what's going on in that moment. So you may need to get more than 1 or 2 EKGs if you're actually seeing the patient declining, okay? All right, basic concepts. Let's get into conduction. Okay, so whenever we're talking about things that are irregular, I always like to review what's regular first, so you know what you're comparing regular versus irregular to, right? So let's bring it back to the basics. Normal cardiac conduction. So the SA node to the AV node, both the atria depolarize, right? Then we go down the bundle of His, down the septal wall via the right and left bundles, both ventricles depolarize. This creates what we know as the normal conduction pattern of a PQRST complex. Any changes will also create a change in the image we see on the 12 lead or the rhythm strip. So great, sounds like very basic, right? But it actually is kind of hard to understand. So we'll look at it from this standpoint. So again, P waves reflect firing from the SA node and atrial activity. This is the first round bump. So here's your P wave. Q wave, the first negative deflection in the complex, may or may not be present, may be a sign of an MI, okay? QRS complex reflects ventricular activity. QRS, this is your ventricular activity. These can differ. You don't always see a Q. We look for ventricular arrhythmias here. So that makes sense. It looks like an upside down V. So this is where you're going to look for your ventricular activity. A T wave, reflects a resting phase of the ventricles. Amplitude changes with electrolyte imbalance, ischemia, and infarction, okay? So remember, make sure your T wave is upright. That's normal, okay? When it's the opposite, that's when we know something is wrong. Okay, normal conduction produces a normal PQRST, right? That makes sense. So here's your normal PQRST, all right? Now, let's just do a quick, I love my animated reviews, especially with things like this. It just makes it a little bit more comprehensive. It's a quick 2 minutes. So let's just look again at how this all goes down with the conduction.
The electrocardiogram, or ECG, is a recording of the heart's electrical activity via leads placed at standardized points on the subject's body. This animation shows how the different ECG waves are produced during a cardiac cycle. The P wave is produced as the electrical impulse travels through the atria, causing them to contract. The P wave corresponds to atrial depolarization. The impulse then travels through the atrioventricular node, producing a flat section on the ECG, known as the PR segment. The PR segment is flat because no current is flowing through the cardiac muscle cells. As the impulse travels from the AV node to the bundle of His and along the upper part of the septum, the Q wave is produced. The passage of the electrical signal through the ventricles produces a large spike called the QRS complex. The QRS complex is much larger than the P wave because the ventricles are much larger than the atria and so produce more electrical activity. Most of the QRS complex represents depolarization of the left ventricle, which has much greater mass than the right. The impulse remains unchanged for a moment as the ventricles remain depolarized. This gives rise to another flat section called the ST segment. As the impulse fades away and the ventricles repolarize, the T wave is formed. Note, this animation shows the ECG recorded from a lead placed at position V6, one of the standard electrode positions to the left of the heart. Leads at other positions detect the electrical activity of the heart from a different point of view, and therefore produce differently shaped ECGs. As you will see, during atrial fibrillation, the electrical activity of the atria becomes disorganized. As a result, there is no P wave on the ECG of a patient in atrial fibrillation. The absence of P waves is one of the most important features used to diagnose atrial fibrillation.
Very important to know that. Remember, the absence of P waves is vital in diagnosing AFib. Okay, great. I hope that was helpful. All right, so now we're going into the basics. So remember, in terms of an EKG strip, usually it's in lead 2. A 12-lead EKG looks at the electrical activity of the heart, essentially from 12 different views. So to perform a 12-lead EKG, we put 6 leads across the pericardium. That reflects V1 through 6, and the remaining leads we call the limb leads. So RA is for right arm, RL is for right leg, LA is for left arm, LL is for left leg. This will give you the typical 12-lead EKG. All right, so here's the placement of the electrodes. I'm sure you guys know how to do this. This is pretty basic. Okay, super things that are important in terms of the basics. So the strip has markings that measure off 6 seconds, which we use in order to calculate the rate, okay? To measure the rate in intervals, we count the boxes on the strip. Each tiny box is 0.04, and multiple number of boxes times 0.04 gives us data we need. If you are reading EKGs frequently, consider buying a pair of calipers or a rate ruler, which are both very helpful and can prevent a lot of detailed box counting. Yeah, for sure. If you work in that kind of in cardiac or cardiology practice, you definitely want to invest in one of those for sure. Okay, PR, QRS, QT, ST, common intervals to measure. So this gives you your measurements. See these boxes? Okay, so important measurements. On EKG paper, remember each tiny box is measured as 0.04. So let's go back. Each tiny box is 0.04, each one of these little boxes, okay? We count these boxes to obtain a rate and various important measurements, including the PR interval. So that measures boxes from the beginning of the P to the beginning of QRS, and it should be less than 0.20 or 5 boxes. So let's do that. So PR interval, it should be less than 5 boxes, right? So 1, 2, 3, 4. Yeah, so that's good. QRS interval measures boxes from the beginning to the end of QRS complex, which should be greater than 0.04 and less than 0.12, 3 boxes. If it is greater than 0.12, we should think of a bundle branch block. And then ST segment, we're concerned about height, depression and elevation rather than widening. So your ST segment, you're worried about how high this goes, okay? Or if it becomes depressed. All right, so the QT interval, we want to measure from the beginning of the QRS wave to the end of the T wave, which represents the amount of time it takes for the ventricles to depolarize and then repolarize. The interval varies with heart rates. Faster the rate, the shorter the interval, which makes sense, right? It's a very important measurement though, because a prolonged QT interval is associated with dangerous arrhythmias like the torsade de pointes, which is a type of ventricular tachycardia. Many antiarrhythmics and other medications like macrolides can cause prolongation, which you'll see in your side effects and warnings. You want to look at that any side effects and warnings on any of the medications you're prescribing. If you see that there's a possibility of a prolonged QT interval, you definitely want to get your baseline EKG for your patient and then just periodically check that, especially if they're complaining of any kind of arrhythmia, chest pain, palpitation, anything, shortness of breath, anything like that. So here we have a shortened QT segment, and here we have a prolonged QT segment. Okay, a U wave, an extra wave that appears when a T wave flattens. We see that in certain disorders such as hypokalemia. So whenever you see this irregular U wave, which is abnormally wide too, you want to be concerned about hypokalemia. Here's a really quick, again, animated review of an EKG or ECG. They're used simultaneously. That is very helpful, just basic review. I wanted you to watch it. It is 9 minutes. It's longer than the typical videos that I like to put up on my PowerPoints because I don't like long videos. I find them a little too much to, bear at times. But this is a really good review, and it's so important that I just figured we should just watch it.
An electrocardiogram, or ECG, or the Dutch or German version of the word EKG, is a tool used to visualize the electricity that flows through the heart. An ECG tracing specifically shows how the depolarization wave moves during each heartbeat, which is a wave of positive charge. And the way it looks depends on the set of electrodes you're using. This particular set of electrodes is called lead 2, for example, with one electrode on the right arm and the other on the left leg. So essentially, when the wave's moving toward the left leg electrode, you get a positive deflection, like this big positive deflection corresponding to the wave moving down into the left and right ventricles. To understand the basics, let's start with an example of how we can look at the heart with only one pair of electrodes, a positive one and a negative one. Remember that at rest, cells are negatively charged relative to the slightly positive outside environment. And when they depolarize, the cells become positively charged, leaving a slightly negative charge in the outside environment. So let's say that when this set of cells is at rest, they're red. And then they turn green as the wave of depolarization moves through them. Now, if we freeze this wave of depolarization as it's moving through the cells, half of the cells are positive or depolarized, and half are negative or resting. And so there's a difference of charge across this set of cells. You can think of the charge difference as being a dipole, because there are two electric poles. We can draw this dipole out as an arrow or vector pointing towards the positive charge. And remember, the electrodes detect charge on the outside of the cell. So this points toward where the positive charge is outside the cell. Now, if there's a dipole vector pointing toward the positive electrode, then the ECG tracing shows it as a positive deflection. The bigger the dipole, the bigger the deflection. If we unpause this, then everything becomes depolarized. And since there's no difference in charge now, there's no dipole, and so there's no deflection. Moments later, a wave of repolarization goes through. Pausing halfway through again, now the vector dipole goes in the opposite direction and faces the negative electrode, which means there'll be a negative deflection on the ECG tracing. Again, the bigger the dipole, the bigger the negative deflection. Now, even though it'd be nice if the depolarization wave lined up perfectly with the electrodes, usually that's not the case. So what we end up looking at is the vector component that's parallel to the electrode. For example, let's say the depolarization happened this way, at an angle. Then we'd break the vector into two parts, one going parallel with the electrodes and one going perpendicular. The one we care about is the one that's going toward the positive electrode, which causes the deflection. Though since this arrow is shorter, it's going to cause a slightly smaller deflection than previously. In other words, the size of the deflection on the ECG tracing always corresponds to the magnitude or size of the dipole in the direction of the electrode. The perpendicular component isn't pointing at the electrode, so it doesn't cause any deflection. In fact, if there's a depolarization wave that goes straight up, which is perpendicular to the positive and negative electrodes, then there'd be no deflection at all. In a standard ECG, there are 10 electrodes, 4 limb electrodes, one on the left arm, left leg, and right leg, and 6 precordial electrodes, V1 through V6, that wrap around the chest. and the right leg electrode is usually used as a neutral lead. Now, the heart's a three-dimensional organ, right? So V1 through V6 line up in the transverse or horizontal plane of the heart, and each electrode is set up to detect any wave of positive charge coming toward them, which based on what we know already means that they're positive. These are collectively called the chest leads. Meanwhile, in the coronal plane, the non-neutral leads are called augmented vector right, or AVR, on the right arm, and augmented vector left, or AVL, on the left arm, both of which are represented as vectors that are 30 degrees up from the horizontal line. Finally, there's the augmented vector foot, or AVF, on the left foot, which anatomically isn't straight down, but it's close enough that it ends up representing the vector facing straight down on the diagram. Just like the precordial electrodes, AVR, AVL, and AVF each detect any positive deflection coming toward them. Now, in addition to these three limb leads, there are also bipolar limb leads called lead 1, 2, and 3, which are recorded using two electrodes instead of just one. Lead 1 uses the right arm as the negative pole and the left arm as the positive pole, forming a vector that goes to the right. Lead 2 uses the right arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 60 degree mark. And lead 3 uses the left arm as the negative pole and the left leg as the positive pole, forming a vector that goes to the plus 120 degree mark. So in total, you've got 6 leads from the limb leads and 6 from the chest leads, leading to a grand total of 12, which gives you your 12 lead ECG. Now, the point of having all these leads is to get different views of the heart, making it easier to see exactly how that wave of depolarization moves through the heart. As an example, consider how the 6 chest leads, V1 through V6, register the depolarization waveform called the QRS complex. The exact same depolarization wave might appear mostly negative in V1 and V2. It might be isoelectric in V3, and mostly positive in V4, V5, and V6, all because of the exact direction and magnitude of the vectors at different points in time. Similarly, each of the limb leads produces its own viewpoint of the depolarization wave as well. Now, all the limb leads and chest leads can be grouped based on the regions of the heart that they're nearest. Problems in specific leads or groups of leads suggest that there might be a specific region of the heart that might be affected by a disease. Leads 2, 3, and AVF are inferior leads because they're near the inferior wall of the heart, which receives blood from the right coronary artery. Leads 1 and AVL, along with 2 of the chest leads, V5 and V6, are all considered lateral leads because they're near the lateral wall of the heart, which receives blood from the left circumflex artery. Finally, V1 and V2 are considered septal leads because they're nearest to the interventricular septum, and V3 and V4 are anterior leads because they're nearest the anterior wall of the heart. Both of the septal and anterior regions are served by the left anterior descending artery. All right, as a quick recap, in a standard ECG, there are 10 electrodes, 4 limb electrodes and 6 precordial electrodes that wrap around the chest. These electrodes are used to make 12 leads, each of which illustrates the movement of positive charge on the outside of heart cells. The ECG tracing shows a depolarization wave moving towards an electrode as a positive deflection, and one moving away as a negative deflection, each of which is proportional to the size of the dipole. The point of being able to get different views of the heart is that it makes it easier to see how the wave of depolarization moves, which provides valuable information about the heart's structure and function. Thanks for watching this video on the basics of ECG. But actually, this is only episode 1 of an 8-part series on ECG. To get access to those 7 additional videos, head over to osmosis.org, create an account, and start your free trial. In addition to extra videos, you can also find tons of other awesome content and tools to excel in your classes and on exams.
So I totally encourage you guys to actually look into doing the 8-part EKG series if you do struggle with EKGs, just to get a better grasp on it. I do love his visuals, especially that last slide where he highlighted in different colors the EKG strip to show you where the different axes are, because I think that's important for you to really learn I'm very
That's
visual when it comes to
the
colors, so I
dipole.
just found that really helpful. Let me see if
The
I
point
can
of being
just
able
show
to
you this. I just love when he did that. I think this is a
anterior
great
descending artery.
diagram. Anyway, so you know where to go, osmosis.org,
All right,
and
as a
then
quick recap.
you
In a
can sign
standard-
up and watch his videos. They're really helpful because I know you guys don't have anything else better to do. And next we're getting into the rate, bradycardia and tachycardia. Okay, so rate, we know any rates below 60 are brady, any rates above 100 are tachy. This is important to grasp because both bradycardia and tachycardia can cause a patient to present similarly because ultimately both cause a drop in cardiac output. So keep that in mind. That's why the rate is so important, because we need to know, are they brady or are they tachy? Because either way, we need to know that specifically so we can figure out the cause of their cardiac output, their drop in their cardiac output. All right, so how do we calculate the rate? So again, this is where you're going to pull out your little pocket-sized reference book, your calipers, and your rate ruler to determine the rate. If you don't have any of those, another easy method is to use your 6-second strip and count the number of R waves and multiply by 10. Okay, so multiply by the number of R waves by 10. So this strip has 5 R waves, and you want to multiply by 10 to get a rate of 50. So here's 1, 2, 3, 4, 5. 5 times 10 is 50. Okay, very simple. You could also divide the number of large squares into 300 for a rate, but that seems like a lot more math than I feel like doing. So I like the idea of just counting the R waves and multiplying by 10. Okay, rate. Where is the beat coming from? So when you're thinking about the rate of this heart of your patient, you're going to ask yourself, where is this beat coming from? If the SA node is not firing as it should, another part of the heart has to kick in to try and initiate a beat. So each area of the heart has its own inherent rate. The rate can therefore help you identify where the beat is coming from. So if your rate is less than 60 or greater than 100, it indicates it's probably originating from a different foci. So the SA node, the normal P waves with a rate of between 60 to 100. In junctional nodal tissue, we're getting bizarre P waves, retrograde. Consider this with a lower rate of 40 to 60. And if it's a ventricular, then we're looking at big complexes, maybe no P wave, and consider this if the rate is low, between 20 to 40. We're very brady there. Okay, basic hemodynamics. So here's your little equation. Cardiac output equals heart rate times stroke volume. Okay, super basic. Cardiac output, which is the volume of oxygen-rich blood coming out of the heart to the end organs which is measured in liters. How do we measure this? If in the ICU the patient has a Swamm-Ganz PA catheter, without it, we can just get an idea by just simply looking at the patient. Okay, so here it is. Here's your volume again. Cardiac output is determined by a heart rate, the heart rate times the stroke volume. Okay, so cardiac output, or CO, is made up of how fast or slow the heart is beating, which is the heart rate, multiplied by the volume of blood that is pushed out with each stroke volume, the SV of the heart. If you can understand this, most of cardiology will make perfect sense to you. That's very broad. I don't know if I agree with that, but it is very important to understand this concept of how cardiac output is. So when there are many changes to any part of the equation, whether there's an MI or an arrhythmia, then it is possible to affect the cardiac output. Often the body tries to compensate by increasing the heart rate or the force of contraction, right? Just to get that blood going throughout the entire body. If able to do that successfully, we say that they are compensating or tolerating the change. If not, then the patient will likely decompensate, and that's when you're going to see confusion, loss of consciousness, diaphoresis, pallor, rales, low urinary output, loss of consciousness, and possibly cardiac arrest. So again, let me repeat that. When there are any changes to any part of the equation, the heart rate or the stroke volume, then it is possible to change the effect of the cardiac output, and that's when the body goes into compensation mode. Okay, so when you think of somebody's cardiac output becoming decompensated, you have to really get a visual of what does this patient look like. So think about any of your patients who are in any kind of heart failure. Any of your cardiac patients, I'm 100% sure as RNs, you've seen patients in cardiac having a cardiac moment of decompensation. So what do they look like? Diaphoresis, dyspnea, shortness of breath, chest pain, organ failure. They're clammy. You touch them, they feel moist. They have an altered level of consciousness. Sometimes they're agitated if they're really struggling to breathe. They have a decreased GFR. They're swollen. A lot of them have pitting edema, especially in their legs. Obviously, congestive heart failure. They have the pallor, loss of consciousness, and again, cardiac arrest. Here's a nice clinical picture of what your patient looks like. I'm sure all of you have seen this particular patient before. And here we can see the weak pulse, cold, moist skin. We have a lot of dependent pitting edema. We have that ascites in the belly. This is your typical heart failure. Decreased blood pressure. We're getting a lot of orthopnea, crackles, wheezing, coughing. They're like gray, cyanotic, very tired, very anxious, confused. You'll see that jugular vein distension up here in the neck. Any fatigue, you're going to see, you may hear an S3 gallop, as well as have tachycardia, as an enlarged spleen and liver, and again, the decreased urine output. These symptoms are very important to know. These you should memorize. You could easily just say, if somebody says to you, what happens when somebody goes into cardiac decompensation? These are the symptoms that the patient presents with, and this you should know. Because obviously, as a clinician, especially a nurse practitioner, you're going to have to make decisions. Like, the biggest thing I find as an NP is giving people the permission to make the right decisions. It's like sometimes people who are even RNs, LPNs, I find that they're afraid, even though they know the right answer and the right next step. Sometimes as an NP, they just wait for you to say yay or nay. So it's very important that you know what the next step is, especially in a patient whose cardiac is, having cardiac issues, or decompensating, I should say. Okay, evaluating cardiac output. Is this patient tolerating the drop in cardiac output? So if the patient is tolerating the drop in cardiac output, they're still awake, they're still alert, they're still talking. Obviously, their skin is warm, dry, good color, they're not pale. Their urine output is greater than 30 cc's per hour. They have minimal to no edema, and their lungs are essentially clear. If the patient is not tolerating the drop in cardiac output and they're starting to decompensate, meaning you're going to be concerned about them going into cardiac arrest in the near future, this is what you're going to start to see. The patient becomes confused, loss of consciousness, pale, cool, diaphoretic, urine output drops to less than 30 cc's per hour. They are edematous. You do hear rales and tachypnea. Okay, they don't look well. It looks like CHF. If it looks like CHF or cardiac arrest, remember, you need to call 911. Do not hesitate. Okay, bradycardia versus tachycardia. How can both patients look alike? So when the patient has bradycardia or slow heart rate, it drops the cardiac output because it is too low and lower or poor perfusion to organs. A fast heart rate with tachycardia drops the cardiac output also, but it is because the heart is beating so fast that the volume of blood with each stroke of the heart is down. The chambers cannot fill and contract and push out the blood as they should. So in the end, this causes a low cardiac output, which means low, poor perfusion to organs. Preload and afterload. So preload simply is the volume that exists in the body pre-heart, which is the blood volume, and afterload simply means the force or resistance that exists in the body after the heart, which equals the blood pressure. So preload is the volume coming into the ventricles, which ends up being your diastolic pressure, and your afterload is your resistance, in which the left ventricle must overcome to circulate the blood. So if your preload is increased, we're seeing that in hypervolemia and regurgitation of cardiac valves. Sorry, guys. Okay. And obviously, if your afterload is increased, we're seeing that in hypertension. Preload is volume. A true measurement of this, again, requires a PA catheter. You may see the term that states preload was too high or too low. To reduce preload, diuretics are given. To increase preload, volume is given, fluids. Okay. Afterload is force/resistance. Again, a true value can be obtained with a PA catheter. We often hear the term afterload reduction, and in fact, certain medications are used to do just that, aka antihypertensives. Why is that? when afterload, also known as the blood pressure, is too high, it causes the heart to work too hard, which over time, as we know, can cause damage to the heart. So obviously, we don't want that. In a freshly damaged myocardium, example, right after an MI, we want to reduce the workload and the myocardial O2 consumption. A way is to reduce afterload to reduce the resistance, the BP, that the heart has to pump again. So we use antihypertensives, thus reducing the workload of the heart. So this is why it's so important as an NP to have your patients with hypertension have their blood pressure under control. Why? Because we don't want to cause more damage to the heart, especially if they've already had an MI. All right, so getting that blood pressure under control is vital in order to manage and keep our heart healthy. Okay, so the cardiac output again equals the heart rate times the stroke volume. Now you can understand and apply this equation to arrhythmias. This is why patients who go into an arrhythmia, like atrial AFib, may become symptomatic. Okay, back to rhythm. Find the beat, find the rhythm, right? Okay, so let's just talk about the normal sinus rhythm again, right? So we want to bring it back to the basics. How do we talk about abnormal rhythms or arrhythmias if we don't remember what the normal sinus rhythm is? So a normal sinus rhythm, this means that the electrical beats are originating from the sinus node following the standard conduction pathway, and it's regular and it's an acceptable rate, which on an EKG produces a PQRST complex, which means it's normal, right? So PQRST, we're coming out of the sinus node, it's coming down the standard conduction pathway, the rate is regular and acceptable, okay? This, after we have our PQRST, which is normal, this produces what we typically hear as lub-dub. Lub-dub, again, normal sinus rhythm. The rate must be between 60 and 100. Again, that's your normal rate, your normal beat, lub-dub. So what we call normal sounding lub-dub and a normal looking PQRST and a normal heart rate equals a normal sinus rhythm.
It's 1 o'clock.
Premature beats. Sometimes a beat will all of a sudden appear out of rhythm and they come in early and there's a little pause before the next beat. The beat may be atrial, junctional, or nodal, or ventricular. We look at the P wave, the QRS, to determine what type of beat. Often by itself, it's benign. May feel palpitations if they start to have several premature beats, but sometimes it's just a random thing. It may indicate a stressed myocardium, ischemia, an infarction, damaged tissues, electrolyte imbalance, medication side effects, stimulants. It all depends on the patient and scenario and type of premature beat. So this is why it's so important you gather your H&P, okay, and really ask questions. What are they taking? Have they been taking any diet pills? What's their lifestyle? Are they under a lot of stress? Have they been having any chest pain? Have they been finding it more difficult to walk up the stairs? Or have they been finding that they're more fatigued more quickly? Do they have to park closer when they get to stores? Like, these are all the kinds of like little things you need to investigate without going crazy because you don't want to freak the patient out. But these kind of little subjective questions are very, very important. Okay, premature atrial contraction, PAC. So a normal looking beat comes in early. So it is a premature atrial contraction, normal P. Usually benign, you may feel palpitation if it's frequent. Okay, a premature junctional contraction, a PJC. Junctional is sometimes also known as nodal. Just keep that in mind. The beat is early and there is no P, therefore premature junctional contraction. Sometimes the P is odd-shaped or behind the QRS. Premature ventricular contraction, or PVC. A beat comes in early, so it's premature and it's wide and bizarre, and there's no P wave. It's likely ventricular, a premature ventricular contraction. Premature ventricular contractions can indicate electrolyte imbalance, ischemia, infarcted tissue. It could be benign, but it may increase and then it will be deadly. If two or more in a row, which are called, if you see two or more PVCs in a row, which is called couplets, or three, which is triplets, or more are runs of VTAC, which we would then lead to ventricular tachycardia. And remember, ventricular tachycardia can be deadly. Okay, so a word about PVCs or ventricular ectopy. May see two PVCs in a row, which is a couplet, three PVCs in a row is a triplet, a string of PVCs is a run of VTAC, and every other one is a PVC is called bigeminy. Every third is trigeminy, and every fourth would be quadrigeminy. The more you use, the more PVCs you see, the more concerning this should be. The more concerning this should be. Okay, yeah. Look for a defibrillator. Get your code card because you want to get everybody around that knows this patient and can help out because this patient may be declining and may go into arrest soon. So here's your triplet PVCs. You got 3 in a row, right? And here's bigeminy PVCs where you have just two in a row. So now let's get into heart blocks and agonal rhythms. So we're going to talk about first, second, and third degree heart blocks. We're going to talk about nodal, aka junctional rhythms, and we're going to talk about agonal rhythms. So first degree heart block, PR interval is longer than 0.20. It's usually benign, and you want to watch to be sure the block does not progress because some medications could cause this. So you see the length here? Okay, Mobitz type 1 or second degree heart block type 1, also known as Mobitz type 1 Winky-Bach, the P waves get progressively longer and then drop a beat, then recycles and starts again. So take a look at this. P waves get progressively longer. See how the P waves start to get progressively longer here? And then all of a sudden you lose a beat. Scary. Okay, so just keep that in mind. So another thing I want to just point out, when you look at this PR interval, the distance between the beginning of the P wave to the Q wave, if you count the boxes, they're progressively getting longer and longer, and then it drops, just as you can see in the picture. And then there's a pause and it resets. Sometimes it's benign. A lot of the times this can be benign, but again, you want to watch this to prevent it from obviously getting progressively longer. Okay, second degree heart block, type 2. So there's too many P's. And in here, we have a sudden loss of conduction. So there may be 2 P's. This is not a good sign because it means a complete or third heart. It could mean that a complete or third degree heart block is probably imminent. But in this particular one, there's too many P's. So the best way to remember this and differentiate it from Winky-Bach or type 1, in that there are extra P's, this is not good. So it's saying that things are progressing and could lead to heart block or third degree, a complete heart block or third degree. So again, too many P's is Mobitz type 2. That's how you want to remember it. Okay, so third degree or complete heart block. There's no relationship to P and QRS complexes. They may all show up on the same strip, but they are independent of each other and the rate may be very slow. This needs an immediate intervention and requires a pacemaker. So when we go into third degree heart block, we need a pacemaker to stay alive, okay? Those P waves are not initiating those QRS waves in this strip. The P's and QRSs are asynchronous on their own. That's not good. The ventricle's inherent rate is low. And if you measure these out, the P to the P is regular, and the R to R is regular, but the P's are not initiating the beat. So if you can identify, it's very difficult to identify the P waves buried in a QRS complex. So anyway, the biggest thing with third degree or complete heart block is you need to know it requires immediate intervention and you want to start thinking pacemaker. Okay, junctional nodal rhythms. The junctional tissue takes over as pacemaker. Note the different looking P waves. They may be retrograde, so many abnormal P's before, after QRS and slower rhythms for some reason. The normal pacemaker is not working and conduction is blocked. Okay, so again, the junctional tissue takes over as a pacemaker. All right, so just look over here where we're circled. These P waves may be retrograde. It's so hard to see because they're so tiny. Okay, agonal rhythm. This occurs at the end of life and is not life-sustaining. So we know this. If we looked at this, we would obviously be very concerned. There's minimal cardiac activity, and here basically the patient is essentially dead. So again, these are one of those rhythms that you need to make sure that you memorize. I mean, this one, obviously, this agonal rhythm is very obvious, but in terms of the other ones, I definitely want to make sure that you can recognize them just by looking at a basic strip. Okay, tachyarrhythmia. Here we're talking about sinus tachycardia, AFib, aflutter, SVT, PAT, or ventricular tachycardia. So sinus tachy is the sinus rhythm, but faster. You get normal PQRS-T waves, but you're obviously in a rate higher than 100. So the rate is usually 120 or less, and there are normal discernible P waves. So it's still sinus, but because it's over 100 beats per minute and it's so fast, it's considered sinus tachycardia. Remember, sinus normal, fast heart rate. So fast meaning it's 120 or less in this particular rhythm. Okay, AFib. AFib is the most common. Atria are in fibrillation. The atria are quivering so fast that many P waves causes a wavy baseline. See all those P waves just causing that very wavy looking baseline. It's an irregular rhythm. It may be fast, but every P is not conducted and the heart filters most out. You may lose an atrial kick and you may have a drop in CO. Okay, so can you see in this that it's irregular? We have a quivering atria, so it can go in and out. You know, in this particular diagnosis with AFib, your prescriptions that you prescribe for these patients must include prophylaxis for CVA or clot, because this can really, anybody in AFib can really throw a clot. So you need to use an antiarrhythmic, beta blockers to control the rhythm, and hopefully you've used some cardioversion with some success. Okay, aflutter. So atria are fluttering. You're getting a lot of P waves, rapid, tends to be more regular. It's got a typical sawtooth pattern. So whenever you see that sawtooth pattern, and you see those flutter waves, think atrial flutter, okay? And the hallmark of this is the many flutter waves. You can get tachycardia, it often comes and goes, but that's how you know it's aflutter. You get those little saw marks. Sawtooth pattern, I should say. Okay, supraventricular tachycardia, SVT. So tachycardia that is above or supra the ventricles. You can't say the exact origin, but it's not ventricular. You want to differentiate the various types and the reentry pathways. This is common. It may be seen in young patients. Their common complaints are palpitations and lightheadedness. Again, in terms of the rate, it's greater than 120, so it's not sinus. It's regular, but still tachycardia because it's coming from above the ventricles, hence supraventricular. So again, the patient complains of palpitations, lightheadedness. They may have low blood pressure, and they can decompensate with this. So you want to make sure you're giving these patients O2, an antiarrhythmic. You want to have them monitored, you know, maybe in the emergency room. We're going to be treating them with beta blockers. We're going to be cutting out stress, caffeine, stimulants. They may need more in order to prevent from decompensating. You definitely want to follow your ACLS guidelines with these particular patients because they can become very unstable very quickly. And of course, you might consider cardioversion if necessary. Okay, ventricular tachycardia or VTAC. Characteristically, these are wide, bizarre complexes. Again, when you see these, you want these strips and you see these particular wide, bizarre complexes, you know you're looking at VTAC. Again, this is an emergency. If sustained, the patient will require either electricity to change the rhythm, an antiarrhythmic, or he will decompensate to VFib. So you go from VTAC to VFib, and then you go to death. Okay, so again, that's why it's so important for you just to be able to look at this little strip right here and say, uh-oh, that's VTAC. We better get some help. Okay, if you can't, you know, I know EKG interpretations are very difficult for some people, and you may not find that you're ever going to even work in cardiology because this is just not your thing. That's fine. That's totally your choice. But as a nurse practitioner, you're still held legally responsible to know the basic emergency things to report, whether you're in a primary care practice, whether you're out in the field doing just education, it doesn't matter. If you don't know those strips, then you're really not in your best practice, doing your best practice. Okay, torsade dispoints. A type of ventricular tachycardia with varying amplitudes of polymorphic complexes associated with prolonged QT intervals, which may terminate or decompensate to VFib. Again, very deadly. The prescription for or the treatment for this is magnesium. You want to correct underlying conditions, cardioversions, and antiarrhythmics. So again, look at this strip and just correlate it always with torsades points. Okay. 63. Okay, VFib. This is an emergency. Again, we said that before. This is a deadly arrhythmia. It requires defibrillation. It cannot sustain life. So if you see a patient in VFib, call a code. There's no perfusion. The course is very wavy baseline. It's shown in all 12 lead EKGs. This patient is in big trouble right now. Okay. Again, this is the hallmark look of it, you know, with these wavy baseline. There's no complexes. There's no ventricular contraction. They're just quivering. So there's no stroke volume and no cardiac output. So obviously we're going to need immediate defibrillation. If we don't have a heart rate and we don't have a stroke volume, we have no cardiac output, right? Again, remember that equation that we learned about earlier. Cardiac output equals heart rate times stroke volume, okay? Okay, an example of a patient in VFib, defibrillated and returned to normal sinus rhythm. Isn't that interesting? Okay. Important. All right, in terms of your patient, remember, even if you aren't quite sure what the arrhythmia is, the most important thing is how the patient is responding. Are they decompensating, clammy, confused, losing consciousness? Always look at the patient and follow your ACLS guidelines. Many times at the bottom of an EKG, an extra lead 2 or V6 strip is run. That is to give you a longer strip to read for an arrhythmia detection. And we'll look at the next slide to have an example. So let's do this. Okay. So self-assessment on Mrs. White. You are a new FNP working in an occupational health clinic at a large hospital. Mrs. White, a 59-year-old obese African-American female, a hospital employee in the laundry, presents for lightheadedness and palpitations while taking clothes from the dryer. She states she had 2 similar episodes at home over the last week, lasting about 15 to 20 minutes. So we have a lot of risk factors here. Obesity. She has a history of smoking times 30 years. She just quit a year ago, but guess what? 30 years of smoking, the damage is done, my friend. Elevated lipids. She has a history of COPD, diabetes. She states she uses 2 inhalers and 2 pills, but can't remember the names, and has a list in her purse in the office. You ask the medical assistant to obtain a 12-lead EKG and see the following. What is your diagnosis? What do you want to do? Explain your rationale for the intervention. All right, let's see. What do we see? So this is what we see. This is what we're looking at. What do we want to do with this? Think about it. Okay, so let's look back. So what are we looking at? We're not seeing any P waves. What we're seeing is atrial fibrillation, an irregular arrhythmia, right? Assess the patient. Is she tolerating this? Like, how is she presenting? Even though she's in AFib, she might be okay. A lot of patients are. Recall that means the level of, so when you say, how is she presenting? Keep in mind, these are the things you're checking. Recall meaning level of consciousness, cardiac exam, lung sounds. Are there rails? What about her skin, pulses, edema, sign of JVD? In other words, you quickly scan to be sure she is tolerating being an AFib, okay? She's not losing consciousness and you're able to examine her and you know she's okay. Because we also want to do a neuro exam because remember, we know AFib is a major cause of a CVA. So we want to get a good baseline neurological exam on her to make sure she hasn't already started to have one or it has already had one. So, you know, these particular symptoms that you're looking for, you're also going to be documenting negative, like they don't have this, their level of consciousness is normal, their cardiac exam is normal, I don't hear any negative for rails. You know, you want to make sure that you pinpoint, especially if the patient is not doing great, you want to pinpoint that you actually did assess and did not find that particular positive assessment, okay, in particularly with a cardiac exam. We know patients can go in and out of AFib. This correlates with her story of 2 prior episodes. Remember, she said that she had like 20 minutes to 2 times 2 of chest pain within the last week. She's feeling lightheaded and anxious. we definitely want to get assistance because we want to prepare her to transport her to the ED. She's going to need a cardiac workup, antiarrhythmics, and stabilization. Now, the one thing I'm going to tell you about this patient, first of all, do you really need an EKG to recognize that she's an AFib? The likelihood is if you didn't have access to your EKG machine, then obviously if you did listen to her cardiac sounds, you would be able to hear that irregular heartbeat. So again, it's super important that you're able to recognize not only visually the EKG strips, but just by listening what AFib sounds like. That's a very, very common arrhythmia. I'm sure you've heard it before and could recognize it. But again, if you would not need an EKG to know this patient is probably an AFib, based on the symptoms she's presenting with, based on the multiple comorbidities, her obesity, her smoking habits, her diabetes, her COPD. These are all very, very obvious factors that could obviously put her in AFib. All right, re-entry to tachyarrhythmia, and we'll talk about Wolff-Parkinson-White syndrome. Okay, AVNRT. Look at this. Oof, that's a lot. There's a lot going on there. Okay, so how do we differentiate it? The P wave appears immediately or just within the QRS complex. Often a pseudo R wave is seen in lead V1 and a pseudo S wave in leads 2, 3, and AVF. Often the onset is after a premature atrial beat with a delayed conduction to the ventricles. In this particular diagnosis, we're treating with beta blockers, CCB, and ablation is 95% successful in treating AVNRT. Okay, Wolff-Parkinson-White, WPW. On a 12 lead, you're going to see a shortened PR interval. You're going to see a slowing and slow rise of the initial upstrike of the QRS complex, which is the delta wave. You're going to see a widened QRS complex, and you're going to see ST segment T wave repolarization changes, generally directed opposite the major delta wave and QRS complex, reflecting altered depolarization. And here it is. It's a very short PR interval, QRS prolongation, and a delta wave. Hallmark features of Wolff-Parkinson-White syndrome. Okay, so what happens? We have a re-entry tachycardia, accessory pathway. It usually happens more in men than women. It's not really a familial genetic thing. They're not really sure about the cause, but how you diagnose it is you look for the delta wave. It's a slurred upstroke in the QRS complex, often associated with a short PR interval. In these particular patients, you want to treat them with antiarrhythmics, digoxin, cardioversion, and ablation. You want to avoid common treatment for SVT and tachyatrial arrhythmias like adenosine, diltiazem, verapamil, and other calcium channel blockers and beta blockers. Hence the need to make sure you rule out prior to prescribing for SVT. Okay, let's get into the 12 lead. All right, so let's just go over 12 lead basic concepts that we need to just be conscious of. So in terms of bundled branch blocks, this is basically an altered conduction to the ventricle, either through a right bundle branch block or a left bundle branch block. On different leads, one can detect which side is blocked. You want to make sure you understand the concept of the axis. The axis is the direction or wave of the electrical impulse, which is typically pulled downward and left, and certain conditions alter this, like a diseased myocardium or pregnancy. And then you want to also make sure you understand what hypertrophy is. So hypertrophy explains that the chambers are enlarged with predictive EKG changes, and typically we're looking for left ventricular hypertrophy. Again, we talked about this at the beginning and the importance of using a systematic approach every time you go to look at your EKG, as well as your any of your radiographs, like any x-rays you're looking at. So remember, just like with the x-rays where you have that consistent system of looking at the anatomical positions, you're going to do the same thing on an EKG strip. So first you're going to be systematic and you're going to look at the rate, then you're going to look at the rhythm, the presence of a bundle branch block, axis deviation, and signs of an MI. Okay. The other there's other methods or other systematic approaches for EKGs. You can adopt whatever works for you, but like in this particular system, we pointed out to you the importance of looking at it in this way because this is really looking for emergency situations before anything else. That would be really important to be aware of. Okay. So other indicators on a 12 lead EKG. There are many other predictable changes that can be detected on a 12 lead. Electrolyte imbalances, drug toxicities, heart disease like pericarditis, coronary artery disease, or tamponade. You can also see any changes that might happen in patients with pulmonary disorders. Okay, bundle branch block, a BBB. So you could have a right bundle branch block or a left bundle branch block. The name implies what it is. It's a branch of the His bundle. Normal conduction pathway for the ventricles is blocked. Many occur due to disease, infarction, and medication. We can tell this by measuring the QRS interval, which should be less than 0.12. If it's 0.12 or greater, it has a bundle branch block. To determine if it is the right or left, we need to see a 12 lead EKG, and we should look for a particular pattern or shapes of the complex in specific leads to determine which one it is. Okay, so criteria for a right bundle branch block. You have a QRS that's greater than 0.12 seconds. You have a slurred S wave in lead 1 and V6, and you have an RSR pattern in V1 where R is greater than R. This R, like you see with that little mark, is greater than this R. So here's a nice little visual of a right bundle branch block. Now, in terms of a criteria for a left bundle branch block, QRS, again, is greater than 0.12 seconds. They have broad monophoric R waves in 1 and V6 with no Q waves. We have a broad monophoric S waves in V1, and it may have a small R wave. So again, the most important thing in these bundle branch blocks is to just be able to understand and recognize what it looks like on an EKG. So for instance, the right bundle branch block tends to look like a rabbit ear in certain circumstances. Okay, left bundle branch block. Again, here is another diagram. So why does this matter? Okay, so a left bundle branch block can skew reading, making MI detection difficult in certain leads. If it's present, note if this is a new finding because it may have occurred due to the MI. So they may have had an MI and now they've developed a left bundle branch block. So you want to make sure that this is not new, because if it's new, then we may have had a heart attack. If it's not new and it's a chronic thing, then you want to just differentiate that it is something the patient has had for a long time to make sure you're not detecting an MI. If a patient already has a left bundle branch block and develops a right bundle branch block or vice versa, that would mean conduction to the ventricles is blocked. If a patient is hospitalized with a left bundle branch block, care should be taken inserting lines like a PA Swan Gans catheter, as that could alter the right conduction pathway, now causing a right bundle branch block. So if we're blocked on both a left bundle and a right bundle branch block, now we're going to have a complete block to the ventricles. Now our patient's in big trouble. Okay, let's get to the axis. Super important. We're almost done, guys. The axis. This reflects the general flow of electricity in the heart. So understanding the concept of the axis is so important in understanding how to learn a 12 lead EKG and really grasp what you're reading. Okay, so just keep that in mind. The axis reflects the general flow of electricity in the heart. It can identify if the axis is moving towards the left, the right, or indeterminate, etc. It gives you one or more pieces of information to make various diagnoses, and we know that specific disorders tend to have a specific axis deviation, like we just talked about before with pregnancy. There are various methods to detect, look for charts, and methods that work for you if you buy a pocket-sized handbook. For this method, we're looking at whether the QRS complex is upright, positive, or negative in various leads. So determine the axis. So in lead 1, it's positive, lead AF is positive, quadrant is left lower quadrant, and its normal is 0 to 90, and so on. Okay, a chart showing, one other thing I wanted to say about this, just so you're clear, typically the electrical flow tends to move away from areas of injury, just so you know that. Usually it moves away from areas. So if you see that the electrical flow of the heart starts to change, then keep in mind, where is it changing from? Okay, because that's where the injury likely occurred. Okay, so here we have a chart showing axis determination through the use of assessing complexes in leads 1 and AVF. What does axis deviation tell you? Depending on where the deviation is, it suggests the following. So this is like a really important slide. So the right axis deviation could be all of these: COPD, left lateral wall STEMI, hyperkalemia. So this is when you see a right axis deviation, you want to consider these differential diagnoses. If you have a left axis deviation, an extreme deviation, you want to consider these. Now, keep in mind, when we get into an extreme deviation and we're talking ventricular rhythms, ventricular ectopy, we're getting in trouble. So again, we want to start to initiate 911 and just get ready to make sure the patient is stable and have everything prepared in case they become unstable. So the beauty of, learning how to look at the axis and really understand the deviation, and if the deviation is right versus left, and understanding these differential diagnoses, it just gives you one more piece of information to help you make the diagnoses. And keep in mind, you don't have to memorize this. This is a little chart that should be in your little pocketbook. So just keep in mind, this information does exist. And when you go to look at your deviation, you can say, oh, I'm seeing a right axis deviation. Let me pull out my book and look at the differential diagnoses that are associated with a left or a right axis deviation, okay? So one of the things I like to point out in NP school and grad school, we give you guys so much information. And yes, there are certain things you need to really make sure you know specifically so you can pass your boards, and obviously so you can do right by your clinical practice. However, the other thing we're really teaching you is how to use this information and where to find it, okay? And that this information exists and there are guidelines associated with it. So you need to make sure you know where to find this particular information at a moment's notice so you can utilize it, all right? Especially if you're in a cardiac practice. Oh, so hypertrophy. Can you tell if the chambers? Okay, so you can tell if the chambers are having issues with hypertrophy if the atrium ventricle are enlarged. So if the atrium ventricle are enlarged, we know we have hypertrophy. It's not imperative to know this for an MI or arrhythmia detection, but it is a more advanced skill. So again, you want to have a resource and access to a resource that can help you determine levels of hypertrophy. Okay, hypertrophy, RVH or LVH. Okay, so right ventricular hypertrophy versus left ventricular hypertrophy. And this is what it tells you, the biggest things you need to know is like, you're looking at a right axis deviation in right ventricular hypertrophy, which makes sense, right? You want to know what your QRS complex is going to look like. You want to know that in an RVH, you're seeing tall R waves in RV leads, okay? Okay, right and left atrial hypertrophy. So ST system tallies the points that are assigned to various indicators of LVH. If we're at 4 to 5 points, this is a strong indicator of LVH. This is where you would see it on the EKG. And in LAH, we notice we have notch P wave more than 0.10 in leads 2, 3, and AVF. Okay. All right, so what does this all mean? Don't get overwhelmed with all these little pieces of information. You're like, well, what do I do with all this? Okay, what does it mean? Hypertrophy chambers can show that there is damage to the heart from other diseases. So a right atrial enlargement in COPD is obviously from high pulmonary pressures versus a left atrial enlargement in mitral valve stenosis is again from a high force pressure. We usually see left ventricular hypertrophy as a result of chronic hypertension because of that high force that the ventricle has to pump against, leading to myopathies. All right. Of course, ischemia, another big thing in cardiac assessment. Ischemic changes occur when the heart is being stressed out and there's not enough oxygen getting to the myocardium. Death has not occurred to the cells, rather they are stressed. So when we start to get into anything that's indicating ischemia, we need to know, because we need to deal with that. Because what happens if we start to get ischemia or lack of oxygen to the heart, something is going to get disrupted here. In terms of ischemia on an EKG, we typically see ST depression in segments that are usually neutral on the isoelectric line or above the line. Okay, so here's what an EKG sign of ischemia looks like. We're looking at ST segment depression and T wave inversion, which is often seen with ischemia. Okay, obviously with ischemia, the goal is to get oxygen to the heart and decrease the myocardial consumption. One simple intervention that meets this requirement is to instruct your cardiac patients when they have chest pain to Stop activity, lie down. Obviously, this gives their heart a chance to take a minute and relax and not require so much oxygen because they're not doing anything when they lay down. They can also take their nitro. And if they have oxygen, make sure you tell them to use it. And you want to increase the oxygen to the myocardium. So when you give the nitro, you're increasing the O2 to the myocardium through vasodilation and increasing blood flow. Okay, now STEMIs, big thing to make sure you learn how to detect a STEMI, EKG signs. Okay, so your Q waves, when you're looking at your EKG and you're wanting to see if you're detecting a STEMI, first thing you're looking at is your Q waves because it occurs before the R wave. That's an older sign. An ST segment elevation in contiguous leads could be minimal or extensive. We could also have flipped T waves. Normal upright will be reversed, and then you may have changes in reciprocal leads. The diagnosis of a STEMI is based on a typical history of chest pain, ST segment elevation in EKG, plus elevation of cardiac markers in your labs. So is it contiguous and reciprocal? So contiguous leads are the ones that are in order, anatomically speaking. These are the ones we look at for the typical changes in an inferior wall MI, because in that particular, so for example, in an inferior wall MI, you're going to see changes in leads 2, 3, and AVF. In reciprocal changes for an inferior wall MI, those should be opposite the inferior wall. Okay, we may see flattening or depression of the ST segment. So here's your site, what you're facing and what is reciprocal. Okay, detecting the STEMI and the surface leads. So it's important to know which leads represent which surfaces. So the inferior represents 2 and AVF. Anterior represents V, 1 through 4. Lateral represents 1, AVL, V5, and 6. And septal represents V1 and 2. And posterior is rarely seen alone. It's tricky. And the EKG is not the definitive diagnostic tool. But if you look in V1 and V2 for tall R waves, that will not be accompanied by right axis deviation. This is often confused with right ventricular hypertrophy. So just remember, we're talking about the left ventricle here, and very few MIs actually occur in the right ventricle, which is a topic for another day. But just keep that in mind. We're talking about left ventricle here. Okay, non-STEMI. This is the problem. You don't see the changes. Okay, hence called a non-ST elevation MI. You may see some ST depression with the ischemia. The diagnosis of an NSTEMI is based on a typical history of chest pain, no ST segment elevation, plus elevation of those cardiac markers in the serum. Okay, so an inferior wall MI. There's no bundle branch block. You do see ST elevation in leads 2, 3, and AVF. Okay, sometimes additional strips are run in leads 2 or V6 for arrhythmia detection, hence the extra leads 2, V6 at the bottom of 12 lead. Oh, the bottom of the page, yeah. So they did an extra one just to really look at it. So leads 2, 3, and AVF. I want you to look at the elevated ST segments. This is also a very low heart rate here, okay, which is often seen in an inferior wall MI. Plus, most likely the RCA is blocked, which supplies blood to the SA node. So this is where you often see various heart blocks with inferior wall MIs. Okay, an anteroseptal wall MI. There's no bundle branch block. Note that the ST elevation in the V leads consistent with an infarct in the anterior wall and septum. Okay, in the anterior wall MI, you want to look at the V leads 1 through 4 for ST elevation. So here's 1 through 4. Okay, Q waves and flip T waves. Okay, anterior lateral wall MI. All right, a quick scan reveals big ST elevation in V leads. Again, they represent a portion of the anterior wall, and the latter V leads consistent with the lateral wall involvement, and there's no bundle branch block. Okay, lateral wall MI. So we have ST elevation in leads 1, AVL and lateral V leads 4 and 5, and maybe some in V6. Kind of, not that much. Also notice reciprocal changes seen in the inferior wall as demonstrated as depression or inversion in leads 3 and AVF. See? And there's no bundle branch on this strip. So in the ST segment elevation in leads 1 and AVL, there's a reciprocal change in the inferior leads. And in lead 2, we have ST depression. In lead 3, AVF and flip Ts. Okay, so let's do a little self-assessment. Mr. Jones, you're working in an urgent care facility, and Mr. Jones is a 68-year-old Caucasian male complaining of dull, aching chest pressure and left arm pain. He has a past medical history of hypertension, and he's on amlodipine 10 milligrams daily. He is a smoker. He has a family history. I don't know what his family history is, but I'm assuming it's cardiac or hypertension. He has pain, which began 3 hours ago with palpitations. You order an EKG and see the following on the lead 2, strip 1. Number 1, what is it? What are we looking at here? And what is the significance? And what are you going to do about it? So we're going to look at this systematically, but just on glance, I'm seeing something I'm not too happy about right now. This is concerning me big time. Okay. Use your method to review the entire 12 lead for signs of an acute event. Please review the following EKG. Again, what are your findings and what do you do next? Okay, so keep in mind, this is a normal sinus rhythm with frequent PVCs. We have trigeminy. It is significant as they are coming frequently in the face of a possible MI. We know that damage or stress myocardium can cause ventricular ectopy. If you're in an urgent care, you may have a defibrillator crash cart present. You want to quickly assess your patient. Is he decompensating? Remember those clinical symptoms we talk about in terms of decompensation. You want to have an RN assess the blood pressure, get your vitals, get an IV going, make sure you have assistance available and nearby in case you need to call a code. And in the meantime, have somebody call 911 if you're in the community. Mr. Jones is infarcting in the anterior lateral wall of the left ventricle. Note the large ST segment elevations in lead 1, AVL, and V leads 2 to 6. See that? Okay. Get an ambulance transport, keep the patient monitored if you have the capability, and proceed with ACLS, BLS protocols. You want to get IV access, more history, administer an aspirin, nitroglycerin for chest pain if available, and most importantly, let's get this guy some oxygen, right? Keep it basic. Get the oxygen, get the nitro, get IV access, get some aspirin if you have it, get his charts ready, get his med list ready, have him ready to go because he needs emergent care. Okay, let's do some review of these test strips and then we're done with this PowerPoint. All right, look at this strip. What are we looking at here? 109. What are we looking at? All right, so I'm just going to tell you this one is atrial fibrillation, AFib. Diagnosis 2. What are we looking at? These sawtooth waves. What are these? What are these? This is atrial flutter. So here we have AFib. And here we have a flutter, sawtooth waves. Diagnosis number 3. What do we have here? This is scary looking. I'll tell you right now, if I saw this, I would be very concerned. We're looking at VTAC here. Okay, woo, a lot of space here. I don't know what's going on. So this is diagnosis number 4. We're looking at complete or 3rd degree heart block. Okay. You know, you want to think about things when you're looking at it. If we're having a heart block, obviously we're not getting beats. So that would make sense that things are spaced out as much as they are, right? Number 5. Oof, very fast. So when we know we're fast like this and we're looking at this rate, we always think supra, right? So this one is SVT, supraventricular tachycardia. And last but not least, This is sinus bradycardia. Sinus brady. All right, here's your answers in case you wanted to review them. And that's it, guys. I know it's a lot, it's exhausting, but you'll get through it. Please feel free to watch the videos that are in this over and over again, or just go over certain slides just to really reinforce certain concepts. We're going to do a little more talk about cardiac stuff in the next PowerPoint, part 2, mostly on atrial fibrillation. Thanks, guys.